Welcome, everyone, to the first official episode of Medical Ethics Unpacked. I'm Dr. Steve Levine, a board-certified psychiatrist, and I'm here with my good friend and colleague, Dr. Dominic Sisti. Say hello to the people, Dom.
Hey everyone, I'm Dom Sisti. I'm at the University of Pennsylvania in the Department of Medical Ethics and Health Policy.
In this podcast series, we're looking to take on some of the most difficult, challenging, and interesting issues in ethics as they relate to the field of medicine and healthcare more broadly. We are starting off today with a discussion of medical ethics in dying and euthanasia, with a particular focus on mental illness.
Yeah, so this is a really difficult topic. I have to admit, I am still trying to work out my basic position on this issue because there are so many strong arguments, I think, from both sides of the debate. We'll zero in on some of the key issues in this debate related to euthanasia and assisted suicide for patients whose sole medical condition is psychiatric. Um, fortunately, Steve here is a psychiatrist, so he can offer some clinical expertise on this, and we'll be drawing on that as well as some of the literature from the past 10 or 15 years on this topic. I think one of the key issues in this debate so basic boils down to the basic idea of the right to die and when an individual has that right. And I would argue that individuals do have a right to decide how they would like to exit this life. The problem is when a person has a serious mental illness, their ability to really competently and autonomously make such a decision seems like it is compromised almost by definition, right? Moreover, several psychiatric conditions, I should say, um, are high risk factors for suicidal behavior and ideation. And so it becomes really difficult to disentangle the wish to die from the symptoms of the particular mental health condition, whether it's borderline personality disorder or major depression or some sort of psychosis spectrum disorder. Um, we'll get into some of the numbers in a few minutes, but I think that's one of the most fundamental questions is disentangling the wish to die from the symptoms of a mental illness. The second issue I think that's really important that we'll talk a bit about is the fact that we can't really determine or define mental health conditions or mental illnesses as terminal. And this is an important issue in jurisdictions where terminality is a requisite or criteria for access um, to assisted suicide or euthanasia. So there's two real important topics I think here within this debate, and that's the problem of determining capacity and the determining terminality. Now, I should also mention that there are jurisdictions where terminality is not required. In those jurisdictions, one does not have to have a terminal condition to access euthanasia. And so it's in those places like Belgium and the Netherlands and Luxembourg and Switzerland uh, where psychiatric euthanasia has become somewhat prevalent. I think the latest numbers I saw in the Netherlands, euthanasia-assisted suicide accounted for um, about 3% of all deaths in that country in 2023. And of those, it's hard to say, but many involved individuals with psychiatric condition. So these are some of the basic conceptual problems that drive a lot of the ethical questions and issues, and we'll try to unpack those this morning.
Thanks, Don. That was a really helpful overview, and you really hit on in those two issues the crux of this debate, as you said, the capacity decision, disentangling the wish to die from perhaps the illness itself, things that are symptomatic of an illness, and the issue of terminality and whether that exists in talking about mental illness. Uh, I bring to this the perspective of a clinician, and I suppose for this audience, I'm representing their perspective. And as a clinician, as a psychiatrist, we're often involved in that determination of capacity. And I think we'll be diving into what the definition of capacity is and how that relates to competence and how that fits into these evaluations. as well as making decisions about prognosis or recommendations about prognosis to patients based upon clinical experience and training related to the condition that might be related to that wish to die.
Mhm.
At the same time, as you lay out, this is such a complex set of issues, and it touches on morality and legality and theology, perhaps even in some ways. And it's why I find it so helpful to have the framework of ethics to apply to this, to think through this in a really thoughtful way. And hence, the really critical importance of your expertise here as a bioethicist, which I think needs to be considered along with that clinical perspective, which can so often, I think, be tinged, whether aware of it or not, by our own personal feelings related to morality and theology, religious beliefs, etc., that necessarily come to bear in these decisions that we make alongside of patients. Yeah, taking a step back, yeah, this question also touches on, higher level, just some basic considerations of what is the value of a human life? How do we feel about that? There, I think, is the general consensus amongst people in this world that one should remain alive, that is the default position. It is our mandate to stay alive. We want other people to stay alive. But the fact is that life itself is a terminal condition, not to be too dark about this. We will die at some point, and people have very strong feelings about what they would feel to be a good death, the death that they would prefer, the maintenance of their autonomy to decide how and when that happens to the extent that that can be within our control. We do place such high value on life that we put strict laws in place, whether it's, here in the US at the federal level, at state levels, internationally, the way that that's handled. We generally agree that it's not legal to end someone else's life, although there are exceptions to that too, in cases like national defense or self-defense
Mhm.
or the punishment of crime. So these things are perhaps not as absolute as we might think about on the surface.
I think we should just start with the capacity question, Steve, and maybe unpack that a little bit with, if you could sort of riff or reflect on some of the ways that you've been trained to assess capacity and how or if those frameworks, and I'm thinking here of Paul Applebaum's and Grisso's framework in particular, whether those, kind of gold standard approaches will really meet the needs of figuring out whether a person with serious mental illness can make such a consequential, the ultimate consequential decision here about living and dying. And I'd be curious of what, you think based on your own expertise.
Yeah, I think that's a great place to start to kind of define our terms when we're talking about the determination of capacity to make a decision. And yes, I can draw on my experience there. Capacity evaluations are often conducted by physicians, and amongst physicians, psychiatrists are often some of the more likely to be in that role. My training is as a psychiatrist in general, as an adult psychiatrist, but I did also do fellowship training in consultation liaison psychiatry,
Mm,
which is essentially the psychiatrist serving as the consultant to medical teams, typically in medical surgical inpatient settings. And a common reason for the medical team to consult the psychiatry team is to evaluate a patient's capacity to make a decision. And as you said, there are frameworks in place for evaluating that. Now, it's important, first of all, to draw the distinction between capacity and competence, because those are two different things, and those decisions are made by different people. Capacity evaluations are done by physicians, other clinicians. Competency is a legal term, and that's typically decided by a judge. So we are focused on capacity here, and capacity is not an absolute. It
right.
is a sliding scale. It's dynamic. It depends upon what the decision is that somebody is faced with, the consequences of that, the complexity of it. So, for instance, the capacity to accept a dental cleaning is
Mm,
going to be very different than the capacity necessary to make a decision about dying.
mhm,
And the components of the evaluation include First of all, an assessment of the person's understanding of the issues. Do they understand the risks of the decision, the benefits of the proposed procedure, treatment, whatever the decision might be, what the alternatives are? How well do they really understand the issues that are relevant to the situation?
Hmm. Hmm.
And from there, can they appreciate the consequences of making a decision? So, whatever decision they make, there's going to be some outcome. And do they understand the connection between the decision they'll make and what the implications are?
Hmm.
And then to demonstrate some capacity to reason through that, to demonstrate that they are making those connections, that there is some logic behind how they are coming to their conclusion. And lastly, that they're able to state a clear choice.
Right. Right. Yeah, I mean, I think this is really helpful. Thanks, Steve. The idea that an individual with serious mental illness is incapacitated seems kind of common sense, but it's not, right? People with serious mental illnesses actually do retain capacity, and when you say that it is a sliding scale and it's decision specific, that means that individuals with serious mental illnesses can have capacity to make all kinds of decisions, even about medication and treatment. And so I think it's critical that we, recognize that fact that almost, the notion that an individual with schizophrenia is somehow unable to make a decision about their treatment is actually false. On the other hand, an individual who maybe has a history of suicidal behavior or is actively suicidal, making a decision about assisted suicide seems problematic.
Yes. And I think it's also worth spending a little bit of time thinking about just that phenomenon of suicidality, right? Because it starts with the question of, is a wish to die or a wish to end one's life, is that always pathological? And if it's pathological, is it always associated with a particular diagnosis or does it exist across diagnoses? And that also had some shades of gray to it, particularly given how common suicidality is in some form or another, even just in the general population who may not have a diagnosis.
Right, right. Yeah, I recently published a paper with Dr. Maria Okendo and John Mann about this very issue, and the idea was that we tried to argue that suicidal behavior and ideation is, generally speaking, pathological. Does it always convert to act to suicide? No. And is it connected to mental health conditions in a way that it is part of them? And the answer is we're not sure, but it seems like suicidal behavior and ideation could be its own almost category of or constellation of behaviors and symptoms, even though it is highly correlated with certain psychiatric conditions like borderline personality disorder, for example, or major depression. It does almost have its own phenomenology, right, at times. And so that makes things even more complicated, I think. The question of whether it's pathological all the time is a really good one. And I would say that it's generally not, it's probably not good. I don't know if it rises to the if I mean I guess if it rises to the level of impairing function, then it begins to become pathological.
Which is our typical standard in psychiatry for making a diagnosis. It's not merely the presence of symptoms, but whether those symptoms relate in some way to level of social, occupational, or other types of functioning.
Right. And so do you think then, Steve, that suicidal ideation behavior, um, a history thereof, or current current presence of that un would almost by definition render a person incapacitated to make a decision about euthanasia?
I'm glad we're starting with such easy topics here, and you're asking such easy questions. Uh, uh, I think another complicating factor is that suicidality also tends not to be fixed. The people's level of suicidality can fluctuate over time. There are different phenotypes of suicidality, and a given person might manifest different types of suicidality over time.
Mhm.
Ducking your question. I'm
No,
not,
it's
yeah.
yeah, no,
Uh,
it makes sense.
yeah. And so, but in that way, if we take a specific example, like somebody with a major depressive disorder who is currently suicidal, suicidality is one of the symptoms of major depressive disorder that can be used to qualify the diagnosis. By definition, major depressive disorder is episodic.
Mhm.
The expectation, although unfortunately it's not everyone's experience, but the expectation is that either without intervention, just because of the course of illness, or with effective treatment, that depression might improve at some point.
Right.
And so it would stand to reason that if the depression improved, the suicidality might improve.
Mhm. Okay,
So,
this makes yeah,
yep.
this makes sense, but it also complicates things, of course. I think, back to the capacity question here, Steve. I mean, I think it's really important then that we have a solid capacity evaluation because if we're wrong, we're basically killing people who are not fully capacitated, and maybe if they were, they wouldn't want to die. So that's the basic problem. And in countries like the Netherlands and Belgium and Luxembourg, Switzerland, there are structures in place to try to ensure capacity of individuals who are asking for this intervention. I saw a paper. This came out a few years ago by Dr. Scott Kim and Marie Nicolini, both of whom are psychiatrists. Scott is at NIH, the clinical center, and Dr. Nicolini is over in Belgium at KU Louvain. And they noted that some of these capacity evaluations are very haphazard, or at least from basically from chart reviews it seemed like they were almost like assertions of capacity as opposed to evaluations of capacity for different patients. And in those countries, there is a high, there has been a high number of individuals with personality disorders, depression, and bipolar disorder who have accessed euthanasia and assisted suicide. So that gives me pause. If the capacity evaluations are questionable. And if you can almost, I mean, I also remember reading that, you can also kind of doctor shop in a way, not doctor shop, but find a clinic that's willing to just vouch for your capacity to allow you to have euthanasia or assisted suicide. So those are some of the, I think, risks around this question of capacity. If we don't get them right, we're going to be killing people who maybe otherwise would want to live.
That's a really, really important point, right? And so, as you said, calls for guardrails in place that ensure that a full and appropriate evaluation of capacity has been made. Another consideration that's an offshoot of that is that typically in cases where people are deemed to lack capacity to make a decision, what follows is an effort to try to restore them to capacity so
Right.
that they'll be able to make a decision. And so if we stay, well, before we go back to the example of depression, and a medical surgical example might be somebody who's hospitalized and has a medical delirium and needs to consent to a surgical procedure. But in the presence of their delirium, they are unable to consent. However, that delirium can be treated and they might be restored to decision-making capacity, and then they could consent to have the surgical procedure.
Right.
In the case of depression, if somebody has a wish to die, but may be suicidal as part of their condition and therefore potentially could be deemed to lack capacity, or perhaps that capacity evaluation isn't done appropriately, uh, theoretically, their depression could be treated, they might be restored to capacity, and their decision might remain the same or it
Right.
might change. But
Yes.
a wrinkle in that is that we also don't necessarily have effective treatments for everyone.
Right. Right.
So that is also a difficult decision in terms of making a prediction about whether somebody could be restored to capacity in this case.
Right. And we'll pivot in a second, I think, to this question of terminal psychiatric conditions. But on that point, Steve, I did see a paper recently that called for the administration of ketamine for everyone who's asking for this to just double check, almost to see, will it maybe resolve the suicidal wish? And I thought that was interesting.
Well, if only ketamine was so reliably anti-suicide. But
Right. But I think, we have these interventions now that we didn't have before, that we didn't know about at least. And if, in fact, you could, you know, sort of restore capacity using an intervention like ketamine, at least for a brief time, and then actually talk to the person about their wishes, that would go a long way, I think. Um, but just a side note there. I think that, the issue sort of grades into this problem of whether or not psychiatric conditions are curable. They're not. We don't really have any cures, but are they treatable such that we could bring a person back to a level of functioning that's acceptable to them, and stopping short of euthanasia or assisted dying. And I think that there's a couple of problems, right? One is that our knowledge and science in psychiatry is still very kind of early, or rudimentary. And also the problem of access to adequate, high quality, evidence-based psychiatric care is kind of limited, is very limited in our country in particular. We don't really have a very solid mental health care system that would ensure that individuals who are struggling with serious mental illness are getting the treatments they need. Um, Finally, I think that there are social structures that both, I think, initiate or cause certain mental health conditions and that exacerbate them, such that those social structures are the real reason for people's desperation often. And unless we, want to just say, oh, well, those are the social structures that we live in, and you're welcome to die now, I feel like that's just a really morally grievous position to be in. And we should address these social structures first before rolling out assisted dying options to people who maybe are struggling under socioeconomic problems, racism, gender-based violence, all of these things. And by the way, the gender disparity in psychiatric euthanasia, particularly in the Benelux countries, is pretty pronounced. I think it's like around 70 or 75% of the patients who die by physicians by euthanasia in those countries are women. And so this brings up a lot of, I think, questions around justice, fairness, equity. But before we get into those, let's just go back a bit to this question of whether and how we can treat serious mental illnesses, and what the limits of the science are.
yeah, it's an important question. There's also the element of time in here as well. Uh, because treatment options, access to treatment options are evolving necessarily over time. There's, of course, always the optimistic position that at some point we may have more effective treatments. In some ways, we may now have some, or maybe on the cusp of some. You mentioned ketamine before, which has been an incremental advance as far as having a rapid acting treatment for certain psychiatric conditions. The psychedelics in development now hold promise for a number of mental health conditions to be perhaps both rapid acting and durable. In schizophrenia, we just saw an approval of a new product that has a new mechanism which could potentially make big differences in the lives of people living with schizophrenia.
Mhm.
And so, some of this I think touches upon the question of if people are suffering and are considering this decision of whether they would choose to die, over what time frame should they have to suffer or be
Right,
allowed to suffer?
right.
Is it enough to say that a decade from now, there could be a treatment that might cure their condition or significantly alleviate their suffering? A
Mhm.
year, a month? What is that? How do you make that decision? We never really quite know what's around the corner. And so, in
Right.
part, these decisions need to be made based upon what's available today. And to your point, also what's accessible to people today in thinking about justice and equity and so forth. And then, another layer on top of this might be distinctions between conditions like mood disorders or thought disorders versus personality disorders. And personality disorders can be a really tricky one, things like borderline personality disorder, especially. That also is something that is potentially dynamic, and oftentimes those diagnoses are made just in the face of having treatment refractory mood disorders or anxiety disorders.
Mm,
There's a psychiatrist, Otto Kernberg, who defined borderline personality organization as a continuum of personality structure from neurotic to borderline to psychotic. And in the presence of an untreated depression, or in the presence of a manic episode, or a significant life stressor, somebody who otherwise might be functioning in a fairly healthy way as far as their personality structure and their defenses and their ability to get along with other people in this world might really be impeded by the presence of that condition, and they might look like somebody who has a personality disorder temporarily.
mm,
And this was something I saw very commonly in my days in treating people with, very severe refractory depression with ketamine, who perhaps had a diagnosis in the past of borderline personality disorder, but when their comorbid major depressive disorder that was so refractory was treated, even in part, in many cases, they still had perhaps traits of that personality disorder, but no longer were functioning as somebody who had a borderline personality disorder.
interesting. Wow, that complicates things for sure. The